Great, thank you very much, Alistair, and good afternoon, everyone. So my name is Joe. I'm an anaesthesia and intensive care doctor based in the Birmingham team with Alistair and colleagues, and I'm also a healthcare AI researcher and PhD student at the University of Birmingham. I'm going to present maybe a slightly unusual talk today, in the sense it's going to be data light but concept heavy, and I'm really happy for it to be more of a discussion than a kind of death by PowerPoint. So with that caveat, let me try and actually share my PowerPoint. I think I'm hoping you can see slides and not presenter notes.
We can. It's perfect.
Always a risk. Thank you. Great. So what I'll be talking about today is my PhD project, which is all around the predictive models and clinical risk scores that we use in medicine generally, but focusing in on perioperative medicine, by which I mean the care of patients who are undergoing surgery, both the kind of preoperative phase where a decision has been made to operate and they're going through the kind of workup, risk planning, trying to modify risk factors and make the surgery as good as possible, the anaesthesia and the delivery of the surgery itself, and then the post-operative recovery all the way through to return to normal function. So that entire pathway is called perioperative medicine, and I'm focusing particularly on the scores used in that period. And I'm particularly interested in looking at those scores, yes, from the perspective of do they work, but particularly do they work well for everyone? I don't want to give away too many spoilers, so let's kick things off. Look, there's an awful lot of excitement about healthcare AI at the moment, and various studies over the last few years have highlighted its potential to match or potentially even surpass clinical experts in particular clinical tasks like diagnostics and prognosis prediction. And these tools, they leverage healthcare data to make those predictions. And there's clear intent from the UK government and from the NHS to support the development and deployment of these tools over the next few years. But what might come as a surprise to some on the call, though I'm suspecting not everyone, is that we've actually been using data-driven models in healthcare for decades. AI just happens to be the latest iteration of these tools. So what I'm talking about today is the earlier generation of predictive models that we use in healthcare, predictive models and clinical risk scores, which I kind of crushed together into a slightly unusual, difficult to say acronym of PMCS. Now, there are hundreds of these scores available in clinical practice with their kind of history in the kind of late 1970s and early 1980s, but they're still in regular development nowadays, and particularly in the literature I know of, which is the perioperative medicine literature. They're cropping up all over the place, and more models are produced and updated every year. Now, these models and scores have lots of different kind of purposes, different uses. Normally, they are at least partially intended to help clinicians judge risk, but they have other purposes as well. And particularly in perioperative medicine, that will be the risk associated with either doing surgery or the risk associated with not doing surgery, and predicting certain common complications like developing pneumonia or having particular organ injuries after major surgery. And just anecdotally, although there are lots and lots of different scores to use from, many perioperative practitioners have their favorites. So they work within a particular area. They maybe look after the same sort of patients on a regular basis, and they use a particular score for various different reasons, which is one they like. But increasingly, these models and scores are being referred to in professional guidelines, and rather than being kind of at the clinician's choice, they're being semi-protocolized. And that tends to reinforce certain actions based on the outputs of those scores. So one particular example I just want to highlight, and this is just an example, there are lots of different examples of this practice. The National Emergency Laparotomy Audit, which is a collaboration between the Royal Colleges of Anaesthesia and Surgery and a few other partners. This is a body that both produces a clinical risk score, but also conducts regular audits of the conduct of major abdominal surgery, major emergency abdominal surgery in NHS hospitals. And one of the standards that they audit against is, I've pulled out a couple of examples here. So that all patients having major abdominal surgery in an emergency should have an assessment of their mortality risk made, and that should be recorded in their notes and made explicit to the patient. And then also that patients who have a high risk of mortality, so a high risk of dying in the perioperative period, and they define high risk as more than 5%, should be transferred directly from theatre to critical care. And so the effect of this is that the risk score that they produced is therefore kind of nudged towards being used, because hospitals know that they'll be audited against the standard of a risk score being used. While the standard doesn't say you must use our risk score, they provide one which is easy to use. And higher risk patients, which they define, then have an action taken, which again is audited against. So if hospitals don't admit those patients to critical care, then that would be considered to be a fail as far as the audit is concerned. Now, this recommendation is logical and really well-meaning and actually fairly effective at improving care. So previous to this, there was quite a lot of heterogeneity of the treatment of these patients. The mortality rate from major abdominal surgery is really high. So anything that can mitigate that and reduce mortality is really welcome. But we have to recognize that it does have an effect of reducing the clinician control over that pathway. And in particular, now that judgment is now ceded to that risk calculator. And so just a really simple visualization of what the pathway might have looked like before and after this kind of semi-automation. So the previous pathway would have asked, a question of clinician, based on clinical data, should a patient go to a critical care post-operatively? There would be some sort of slightly fuzzy decision-making process, which probably the clinician couldn't fully explain how they were coming to a judgment, but they would come to a judgment based on the information they had and then make a choice. But what happens now is that that same data is available and the same question is asked, but the clinical algorithm is applied. And in some regard, it now kind of pseudo-automates that process. Now, obviously, there's an important caveat that normally there is still human oversight of that decision. So it's not saying the patient automatically goes to critical care, no one gets involved in that choice. That's not quite true, but certainly the algorithm will have an influence over that choice. Now, I think this new semi-automated pathway has real benefits, and semi-automated pathways in healthcare have benefits generally. So humans, we're fallible beings, aren't we? We can be unfairly influenced by our prior assumptions, including our unconscious biases and any kind of overt discrimination in some cases, unfortunately. And also, semi-automated pathways are somewhat easier to monitor via process measurements. So in the NELA example, we can measure the number of patients who have their risk score calculated, and also of those high-risk patients, the number that go to critical care. The only outcome you could measure from the traditional clinician decision pathway would be the outcomes. So do patients go on to survive or die of their surgery? You wouldn't have that process measurement. So the outcomes, the monitoring of that system running happens a little bit later on. You're further away from being able to influence it. And also an important other benefit is that decision-making can take time and it's quite energy intensive on the behalf of clinicians. So offloading that in some regard frees them up to do other tasks and to focus their time potentially on tasks where actually there isn't a good automated system. But we do have to recognize the costs of automation in healthcare, even if it's not complete automation. I think a really important one is that there's no such thing as a perfect automatic system. So there'll always be a degree of error or inconsistency in the system. Simply, you can't design a system which works really well for everyone. There'll always be someone who loses out. And when you apply these systems at scale, it means that any biases or errors are applied at scale as well. So rather than one particular clinician maybe making judgments which aren't quite perfect, you're now making slightly not perfect decisions for every patient in the entire NHS. And even a quite low rate of error can suddenly translate into a lot of patients experiencing that bad event. Also, to some regard, the fuzziness of clinical decision-making can be a strength. So for those familiar with the wisdom of the crowds, we hope that each individual clinician is highly trained and experienced at making judgments, but they'll be wrong sometimes. But if we average across an entire population, on average, the decisions tend to be good. So at the average population level, clinicians tend to get it right more than they tend to get it wrong. But obviously, when you're applying an algorithmic system, you get the same judgment for everyone based on similar inputs. And I think another important thing to recognize is that removing clinicians from that decision-making process to some extent means that we're less well equipped when we then have to make decisions in the future to ground those decisions in previous experience. You can't always rely on these automated decision-making systems. Sometimes you just can't get to the computer in time to calculate the risk score, so you have to make a judgment now. But equally, sometimes you're operating outside of the scope of a clinical judgment, clinical decision system. And as a result, if you have less experience in making those judgments and getting them right, because you haven't had that feedback from being forced to make previous decisions, well, your decisions may not be quite so good in the future. So the backup plan for when we can't use these systems maybe is slightly less good. And also, they just feel a bit unjust and inhuman at times, which is an important thing in healthcare. And whilst clinicians normally are in the loop and normally are in some way responsible for making these decisions, there are a few examples of where human control has been ceded completely to autonomous processes, often with the best of intentions, it has to be said. So a good example is this FT piece, which picked up the allocation of donor organs in the UK. So in the UK, like many other countries, there's a critical shortage of donor organs for patients that have a need of organ transplantation. There's just not enough to go around. And the choice of who gets an organ and who doesn't is a difficult balance between different ethical principles of justice, individual patient need, their ability to benefit, the cost effectiveness of offering them that organ at that time, and many other factors. And often it boils down to a choice between several extremely deserving patients. And so how do you choose between them? Well, the National Liver Offering System was launched in 2018 to match livers to the best recipient. But obviously, the concept of the best recipient is a value-laden judgment. And whereas previously the best patient would have been judged by people, now the best patient is judged by an algorithm, but the algorithm was made by people. So what we've done is we've automated that value into now an autonomous system. And the choices made during the design of that algorithmic process now influence patient outcomes. But importantly, when it comes to this system, clinicians are not able to overrule, and patients are entirely at the behest of what the algorithm says. And in a way, all of this would kind of be fine. So automating healthcare systems would be okay if we knew that the models we were using worked well. But the reality is we just don't know this, or we don't have the evidence for it. So in the scope of perioperative medicine, the National Institute for Care Excellence, in kind of August 2020, when a lot of us were working quite hard in COVID wards, they snuck out this evidence review of the predictive models used in perioperative medicine. And they flagged that basically they couldn't really assess the quality of evidence because it was so poor, a lot of heterogeneity between studies, inconsistency in outcome measurements, and simply just inadequate data to be able to say what models are best to use for certain situations. So NICE were not able to offer guidance on which ones we should and shouldn't be using. And this isn't just a problem with perioperative medicine. So there's a wealth of literature from across healthcare, much of it led by colleagues across the West Midlands, particularly team at the University of Birmingham, but also others, highlighting that this is a systematic problem with the way that we develop, validate, deploy, and interpret predictive models in healthcare. And that by encouraging widespread adoption without proper scrutiny of the effect it has on clinical decision-making and ultimately the impact on patient care, is a risk. And to make matters worse, the more we look into the way we deliver healthcare, and particularly when we're relying on devices, sensors, scores, and algorithms, the more we look into this, the more we recognize that the burden of error and risk is disproportionately weighted to certain groups in society. And usually it's those who already experience worse health outcomes, and the effects of systemic oppression, discrimination, and oppression. And marginalization, I beg your pardon. So I guess the question we have to ask is how sure are we that the predictive models we use in healthcare every day are accurate and fair? I want to take a bit of a step back and have a pause at this moment just to kind of reassure everyone that I actually think my worldview is that predictive models can be a net force for good. I think they are useful, but I don't think they're a panacea. I think that we should think of these as tools. I think they are tools, and tools need to be used for the right task. And if they're misused, they can lead to harm. And also, not all tools are equal. So some tools are poorly made and actually just shouldn't be used at all, regardless of their purpose. So we need to understand and transparently communicate the limitations of their tools, and also when they do have particular benefits. And we shouldn't see the communication and understanding of limitations as a value judgment, either of the tools themselves or the people that made them. But we should see it instead as a critical means to ensure patient safety when we're moving towards more autonomous processes in healthcare. So that kind of brings me to kind of what I want to do about it and the aim of my PhD work. I, over the next couple of years, I'm going to be conducting a explanatory sequential mixed methods research project, which is then followed up by a validation study of a subset of the highest risk scores in perioperative medicine. Because right now, I don't think that we know which predictive models are used. I don't think we know when they're used. I don't think we know what purposes they're commonly used for. And really importantly, we don't fully know how they're impacting patient care. As I highlighted at the start of the talk, often these tools are used at an individual clinician's behest, so they just choose the one they want. But we haven't had a lot of scrutiny over the guidelines and recommendations coming out from professional bodies to use certain scores. And as NICE flagged, often those scores don't have sufficient evidence base behind them to support such recommendations being made. So I want to maximize the health equity when these models are used by, first of all, understanding, calculating, and comparing performance across key demographic subgroups. And if it's possible in the conduct of that analysis to recalibrate and update the models we pull out, so that at least the models we have right now work slightly better for the data and the patient mixes we have available. But then I think the more important and more exciting thing for me is generating knowledge and guidance that will drive better quality predictive models and AI health technologies in the future. Because if we can understand some of the limitations of the statistical development, validation, and monitoring, but also the deployment and human factors associated with these models, then I think we can do better in the future, basically. So the first body of work that I'll be leading starts in the next few weeks, and this is a scoping practice of current practice regarding predictive models. So I'll be surveying NHS perioperative clinicians to understand which tools they use, in which context, and how they perceive these scores. I'll follow that up with a focused literature review of those scores, looking at each score's kind of original development papers and any subsequent validations, and producing a taxonomy which basically combines them into different modeling techniques. I'll be trying to track the data sets used and the use cases, and producing a summary of all of that. And then convening an interdisciplinary workshop with patients and healthcare professionals to risk stratify the scores that we've pulled out as being commonly used, to work out which ones we need to look at in more detail. And the questions we'll be asking in that workshop are, what are the risks if these tools go wrong? How likely are those risks to happen? What's the consequence on patient care if they were to happen? And how able are we to identify if such a risk or such an error has happened? So as an example, if a risk score is intended to predict whether or not someone will die, and the likely use of that model would be to judge whether or not they should have surgery, then obviously that would be an extremely consequential risk score. Because if a model failed to classify someone as high risk when they were, then the effect of that might be that surgery is withheld and the patient then dies from their from their condition. The next part of the research project is a qualitative research project. So this is an interview study of anaesthetist surgeons and intensive care doctors, so those professionals who most commonly use and will be influenced by predictive models and risk scores. And the intention of this project is to understand how they choose and use those models. So particularly focusing on aspects of score performance and fairness, asking clinicians, do they think about this when they're choosing scores? How do they choose their scores? And what impact does it have on the decisions they make? And then the third and final work package as part of this body of work will be a validation study. So those scores that we pulled out from the first work package as being the most consequential, we're going to curate a bespoke perioperative care data set to basically try and analyze the predictive performance of these scores. But I think more interestingly, for me at least, to test them to breaking point. So in which situations and subgroups do they not work well? And we'll be defining the subgroups both a priori, based on our understanding of certain clinical conditions, so which patient groups are most at risk, given what we know about this particular disease and this particular surgery type, but also allowing ourselves to be somewhat led by the data. So using clustering approaches to group together patients who are most likely to suffer ill consequence, and then looking back to see what's similar between them. Because it might well be that when we apply that sort of model, we find groups of patients are pulled out as being particularly of high risk from model malperformance, where we wouldn't have been able to identify that a priori. And I think all of this will ultimately, hopefully, lead to improved patient care by, well, firstly, letting us, at least for those models we validated, work out if they're suitable for use, full stop, and also which groups they probably shouldn't be used for, because we either don't have evidence it does work, or we have found evidence they don't work. So we're trying to protect patients from currently used models. But we'll also be producing a roadmap, tools, and knowledge guides for developers and for people deploying these models in the future to choose and use and create models that better meet patients' needs and actually can go some way to reducing health inequity. And then a critical third part of the project towards the end phase will be the dissemination. So there's no good me spending 2 years jumping up and down saying these models have problems and this is what we need to do about it if the right people aren't in a room hearing that message. So a really key part of this work from the off has been identifying those key stakeholders who will help us drive the change in the system so that any of our findings can actually be translated into impact and patient benefits. So that's quite a lot of speaking from me. I'm going to leave you with 3 main messages and then really happy to open to discussion and take any questions. So I think we need to think of predictive models as tools, and that tools have purposes. We shouldn't assume that they work well for everyone. In fact, we shouldn't assume they work well full stop, but particularly we shouldn't assume that they work well across subgroups. And it's really important that we don't just think about this as a statistical question, but as a whole system question, because ultimately these tools are normally deployed into complex decision-making processes which involve human beings. And so, yes, statistical performance is really important, but the way that these tools are used and sold to clinicians is also really important to understand. So thanks very much. I'll stop sharing, but happy to take any questions.